Chandrima Paul wants to be the first speaker as she has some commitment elsewhere. And she's the director and consultant of the glaucoma services at BBI Foundation, and also the pride of GSI, the Honorary General Secretary. And we look forward to hearing from her on optic disc evaluation, preferred practice guidelines. Thank you.
Thank you very much, Dr. Chitra, for this invite. It is indeed a pleasure to be here this morning. And I'm sorry to disrupt the flow, but I have an instruction course which I have to rush to. So I'll take you through optic disc evaluation, which I feel is the cornerstone of glaucoma diagnosis. I'll keep it short and sweet so that, in the interest of time, otherwise you could actually talk on the optic disc for the whole day. Anyway, high intraocular pressure is not primary open-angle glaucoma, and we've seen that many a time a patient might come to you with high intraocular pressure but does not have any other glaucomatous features. So disc changes precede visual field loss in most cases. So that's the normal disc that you see, the neuroretinal rim, which generally is pink and carries actions of the retinal ganglion cells, the central cup, the white depression, the horizontal diameter less than the vertical diameter, and usually the horizontally oval is the normal cup. And that's when we have a disc which is suspicious or has some pathognomonic changes. And finally, we have the advanced discs that you see out there. These are just schematic diagrams. So I would always say to keep a drawing of the disc as you see it, because there's observer variation and someone else might see the
Dr. Vinay,
disc,
first row.
but seeing
Dr.
your
in the first
diagram would know what's happening. And that's just to go through the alpha and beta zones. What we are interested in is the beta zone.
Dr.
And the scleral lip, the scleral tunnel rim is actually what we see as the a cup. And next we move on to the 5 R's, which you all are very familiar with. The scleral ring to identify the limits of the optic disc and identify the size of the rim. Next is the retinal nerve fiber layers, which you need to see very carefully. Examine the region of parapapillary atrophy and look for retinal or optic disc hemorrhages. So the optic disc, as we see it here, that's the scleral ring and the vertical disc diameter and horizontal disc diameters, which I just told you about, and the measurements according to the lens that you're using at the slit lamp, the high plus lenses, and the manufacturer's constant for those lenses, and that's the average vertical and horizontal diameters. So the size of the cup varies with the size of the disc. Large discs would have large cups where you would diagnose glaucoma more often than you would do in small discs with small cups, where you actually might miss the diagnosis because of the small size of the disc. And next is the neuroretinal rim, and that is what we are actually interested in. So it's like a donut where we're interested in the chocolate and not really the hole in the center. And the area, the configuration, and the pallor that you see in the neuroretinal rim, and that is the loss of rim tissue which goes on in glaucoma. The isn't rule, which you all know, the inferior border followed by the superior nasal, and finally the temporal. That's the order in which it should go. Any deviation from that needs follow-up. That's the neuroretinal rim and the isn't rule. The parapapillary atrophy, as I told you, we're interested in the beta zone, the zone right next to the disc, which shows up, and not the alpha zone. So the optic disc hemorrhages, that's the most pathognomonic area, of course, is the inferior part of the disc, and that would generally disappear in 2 to 6 weeks and get converted to a notch. And that's the notch that you see out there. And then we come to the RNFL. A lot of talk about RNFL in OCTs and everywhere else, but as you actually evaluate the disc, it is probably one of the surest ways that you can see. If you see it in red light, you would see those bright silver striations that you see out there, and then you can grade it: moderate, mild, moderate, and severe. And there's diffuse and localized RNFL thinning as well. The cup to disc ratio, we generally assign a 1 to the entire disc, and then you calculate it according to the neuroretinal rim that you see out there. So if you consider this, then say it's 0.10, and that's 0.10. So this would be, say, a 0.80 cup, and similarly goes on for the others as well. And asymmetry of cup size is actually one of the pathognomonic signs. More than a cutoff of more than 0.2 would definitely require your attention, but you can also get them in other congenital anomalies, which you have to be aware about. And these are features which you see, like notching and focal loss. Then you have the acquired pit of the thing, which you have to be careful, or the diffuse rim loss, nasalization of the vessels. I'll just run through these because in the interest of time. Bayoneting vessels, these are very pathognomonic sign. The bending of the vessel that you see as it lifts the disc margin, that's very important, that is there. And the hallmarks of correct evaluation of the optic nerve head in suspected glaucoma: measurement of the vertical ONH size at the slit lamp with dilated pupils, detection of the vertical and horizontal CDR, and careful consideration of the association between optic disc size and optic cup size, assessment of the integrity of the neuroretinal rim, and the review of the characteristics of the isn't rule, exploration of the presence of beta zone, assessment of the optic nerve head for the presence of vascular changes, like barring or of the vessels, or nasalization of the vessels, or arteriolar thinning, and assessment of the peripapillary and retinal nerve fiber layer integrity, and exploration of focal or diffuse retinal nerve fiber layer defects with a red-free filter. So thank you very much for your attention.
Thank you very much, Dr. Chandrima. That was a very good talk of yours, which covered everything. I want one question to Dr. Vijaya. Now, you have a patient with a splinter hemorrhage when you see the disc, and if the IOP looks quite decent and low target, otherwise for the disc size, would you go after that splinter hemorrhage and further lowering, or would you evaluate more? What would you do? I want mics for what has happened. Where is audio visual? So sorry. I keep one more mic, please.
Yeah. Thanks, Chitra. Splinter hemorrhage, does it mean that the disease is likely to progress?
Yes.
So there is a need to re-look at all the parameters. Possibly you have to look at beyond IOP also if needed.
Yes.
Because at least in our scenario, we don't see splinter hemorrhages in all POAGs, but we do often see them in the NTG. So if you see a splinter hemorrhage, there is a need to relook at your target pressure, whether the patient is taking the medication, is there any concurrent use of the steroid that would have caused the rise in pressure. So there is a need to address a lot of things. You may not see any progression at that stage, either with your OCT or with HVF. If you wait a couple of months, when the hemorrhage disappears, you do see definitely a progression in the visual field and the OCT.
Yes, thank you.
You have to relook at it.
Thank you very much. I have one question to Dr. Satyan. What would you say is the relevance of disc damage likelihood scale for resident training? How would it differentiate them?
It's a difficult question for me to answer that, because I'm not sure how many of us really follow the DDLS scoring system, but with the advent of other methods like OCT with like BMO, I think we will be going to the next level rather than just looking only at that. But the importance is small disc with the small cup is important, large disc with the large cup may not be having a glaucoma. So that is one thing which we can really look at.
I also wondered, each time that sometimes the patient is seen by different consultants, if we make it a habit, I'm sure you are an expert, but if we make it a system that all the consultants write down the disc damage likelihood staging when they see the disc, the next time you see, right from the beginning itself, you know there is some change which is happening, no?
I think more than that, I would suggest it's so easy to capture a picture.
Actually,
You
I was
have
about to say
picture
that.
in the standard magnification.
Yeah.
If you have in your EMR as a part of it,
Absolutely.
it's always, because again, your assessment of the disc can vary.
Really.
Yeah.
That is exactly I was
Yeah.
trying
So
to
how often should the fundus disc photographs be taken, and
There
is
is
there
no
any
often, it is a must, that's it.
for every visit?
You do it every visit?
That's what I'm.
No, not every visit.
That's
No,
what. Like,
that's
how
what-
often means every 6 months or 1 year?
No. If you see,
Minimum is
If
yearly
there is
once.
a change, if you suspect a change, take it again.
yeah.
Yeah, minimum I feel is yearly once is.
I would
Yes.
want, thanks Dr. Chandra.